Hello, my farm friends, Dr. Bratt. This chat with Bratt is about type 2 diabetes and drugs that we use to treat it. So in our last presentation, we talked about drugs to treat people with type 1 diabetes. This one's going to be to extend that conversation about patients with type 2 diabetes. So meet Mr. Greely. He's 62 years old. He was diagnosed with type 2 diabetes about 16 years ago. He has hypertension, he's overweight, he's got some signs and symptoms of renal failure, cardiovascular disease, and some early stage retinopathy. And these are all very typical of patients who have diabetes, so that's not uncommon to see these types of other comorbidities along with diabetes. So he's taking two drugs, metformin and sitagliptin, to control his blood sugar. So let's take a look at some of these drugs. So when we're looking at type 2 diabetes, it's also sometimes called non-insulin dependent diabetes. It basically is related to that the body's making insulin, but for some reason the cells are being resistant. They're fighting against that insulin. And it also can be related to that there's just not enough receptors on cells for insulin. Remember that cell and the lock and the key, so we can get the cell is not opening up the door to the insulin even though it's there. And this is what results in type 2 diabetes. So if we look at it in a schematic, you can see what happens in type 2 diabetes. So we basically, again, we eat, we take carbohydrates in, it produces glucose, which goes into blood vessels. And what happens, we can't get into the cells, which is similar to some of the problems we have with type 1 diabetes. But with this one, we do have insulin production, but it's not being effective enough to get it into the cells. So pancreas makes insulin, and it just isn't being used effectively. So it needs a little bit of a boost. And that's why we put patients on drugs that's going to boost the body's normal mechanisms to take the glucose out of the blood cells and put it into the tissues. So let's look at these drugs. And the basic action of oral agents is that they basically are going to do a couple of things. Is that they're going to either increase insulin secretion, so there are going to be drugs that are going to basically kick the pancreas and say, you need to produce some more insulin for me. And these drugs are only going to be able to work if the patients have some insulin secretion, that they've got some healthy beta cells that make the insulin are still functioning. And these are three of the drugs that we're going to talk about. And then there's going to be drugs that are going to reduce insulin resistance. So what these drugs are going to do is, again, that lock and key. These drugs are going to kind of make that door open easier to allow the insulin that the patient's already secreting to open up that key to let the glucose go into the cells. So it's going to help to make those cells more receptive to insulin. So two drugs that we'll talk about there. And then last one is there are drugs also that mimic other hormones that basically, again, can kind of help that normal process of taking up glucose and putting it where we need it, so that we can maintain normal glucose levels. So these are just some examples of where these different drugs act. So some drugs can help to try and decrease the carbohydrate load because that'll decrease the glucose levels. It can also be helpful to use other types of drugs that are going to work with the liver by decreasing glucose production. So it's going to kind of slow down the liver from converting that glucose into glycogen in the liver. It's also going to help to take sometimes fat tissue to take up the glucose better. So again, it's taking up the glucose into the cells better. It's also, some of these can directly stimulate the pancreas to produce more insulin, and others can again drive glucose into cells a little bit easier. So this is the major mechanisms in which these drugs work. So when we're looking at drugs, all the drugs to treat diabetes can create one of two things. They can all create hypoglycemia versus hyperglycemia. And it depends upon, again, what the patient is. So I just put this table together for you so you can do a comparison and contrasting. It's kind of in your book as well. But what I did in this table for you that I thought would be helpful is that it kind of shows you that certain symptoms are the same. So sometimes it's hard to tell the difference. So for example, the CNS, both of them can cause altered mentation, confusion, and coma. If the hypo or hyperglycemia persists, they both can cause tachycardia. They both can do something to your skin. Hypoglycemia, the patient tends to be more cold and clammy. Hyperglycemia tends to be more warm and flushed. Both of them can cause nausea. Because of the hyperglycemia, it can cause that with the GU, cause an increase urination, increase urine output, and because that patient becomes thirsty, it can also create problems with ketones. And the respiration is another thing that distinguishes it. They can both have rapid breathing. Typically with hypoglycemia, it can be rapid and shallow. Hyperglycemia, it tends to be a little bit deeper to try and blow off those ketones. Remember, that's acid and that fruity breath. So that's a distinguishing feature of hyperglycemia and ketoacidosis. And onset, usually hypoglycemia comes on a little bit more slowly, or excuse me, suddenly. And hyperglycemia tends to be a little bit coming on more gradual because you don't all of a sudden go from having normal glucose to being hyperglycemic when you have diabetes. So let's take a look at the drugs. I know that this is kind of a very kind of and the sun's coming in. I'm just got close here. There we go. All right. So this is kind of a very busy diagram, but I will also attach it to the presentation. But what I did for you here is identified the 5 drugs, 1, 2, 3, 4, 5, 6, 7 drugs that are on your list for this unit, and identified you what the actions of those drugs are, and then the side effects of those drugs, what the cautions and interactions are, and the nursing care associated with that. So what you see here are basically in the first 3 drugs here, the sulfonylureas, the gliptins, and the meglitinides. These all are going to promote insulin release, okay? Insulin release. So anytime you're increasing insulin release or promoting insulin secretion, the side effect is going to be hypoglycemia, hypoglycemia. Okay, so that's a distinguishing feature. So think about when you look at those drugs, are they causing the body to do something with insulin? So if we're trying to nudge insulin, the insulin's major effect is to cause hypoglycemia. It's to take glucose out of the bloodstream, put it into cells. So remember the side effects of these 3 drugs. Because of that, we have to be monitoring patients for hypoglycemia. Going down, the biguanides, one of the things that a very important thing here is that it doesn't work by promoting insulin. It works by cutting down on the carbohydrates. So what it's doing are glucose stores. So what it's doing is trying to decrease the GI uptake of carbohydrates and absorption of glucose, and to stop the livers from production of glycogen and glucose stores. So that's what makes this one unique. So what happens with this is that there can be a problem with lactic acidosis. And this is one of the big side effects of metformin that needs careful monitoring for, which will be taking place in your nursing care. So the alpha glucosidase inhibitors also work on that carbohydrate side. This one is trying to delay the absorption of carbs when we eat them, again, so the patient doesn't get this really rapid glucose load, gives the body a little bit more chance to kind of settle down and realize, okay, I got to step up some insulin production. And so that is another mechanism of action. But this one also is a little hard on the liver, so you need to monitor your liver function. Last one are the glitazones, and this one is again working in the cells to basically help those cells to uptake the glucose stores, okay? It also works with the liver to decrease the production of glucose glycogen, okay? So remember, these 3 are kicking the pancreas to produce insulin. These are working on the other side of the equation to decrease that glucose load by slowing down carbohydrate uptake and absorption, and to increase uptake of the cells and open up those cells to the the insulin so that, increase the uptake of cells to glucose so that the glucose goes into the cells and doesn't stay in the bloodstream. So that's just a really nice summary of the drugs to treat type 2 diabetes. So I also wanted you to know when should you call the provider? I know you get questions on this all the time. So you want to notify the provider if the patient is having severe symptoms of hypo or hyperglycemia, because that's going to need treatment. If they're hypo, they're going to need some form of glucose. If they're hyperglycemic, they're going to need something that's going to bring that blood sugar down. If the patient's having kidney problems, that's with the metformin, liver dysfunction, pancreatitis, signs and symptoms of congestive heart failure. These are all serious side effects and may warrant the patient being taken off of the drug and interventions to deal with these. The last couple are blood glucose outside of the target range. We want to keep the glucose levels within normal so the patient isn't hyper or hypoglycemic. And if the patient is unresponsive, for example, if the patient is going, of course, into any type of ketosis, and this is something, of course, that you want to be monitoring the patient for. So as far as patient teaching goes, we want to think about what is essential for patients to know. They need to know if they are in good control. The way that they can tell without checking their blood sugar is if they're having signs and symptoms of hypo or hypoglycemia. And this is important that they do know what those are. And patients are going to vary. Some patients really know that they are becoming hypoglycemic, that they need to do something, they need to eat something. So also glucose monitoring is important, and teaching patients how to do that home management is important to be able to know, again, when they're in control. And again, they need to know what to do if they are ill or stressed, because that's going to change their need for their therapy. If a patient has type 1 diabetes, they might need more insulin. Patients who have type 2 diabetes and now are ill might need to add insulin to it to keep their glucose levels within normal limits. So that is just kind of a nice summary for you about the drugs to treat type 2 diabetes. I hope you found it helpful. Reach out if you have any questions. So you take care. Bye-bye.